Fabio is an MD. He's a clinical researcher, and he also happens to have had COVID-19 in the last 3 months.
Yes.
How are you doing? How are you doing now after 3 months?
Much better. Finally, still a little bit, 2 steps forward, 1 step back, but definitely on the mend.
Good. I'm glad to know that we've got you more fully present to help us figure this out.
I'll try my best. Thank you.
So I want to ask you, really, I want to define what is this enemy. We have new cases coming up. They're spiking right now. This is late June, and we've got these, it's spiking all over the country. Like 10 cities are all seeing record numbers of highs. And are we supposed to be surprised at this?
I really don't think so. I think this was fully predictable. We know from previous experience and in different countries that the level of lockdown and the extent of the lockdown until reaching a peak and seeing that peak declining, that's really when you can start opening up again with a lot of caution, knowing that as soon as you start reopening, the spread of the infection reaccelerates. So essentially, we're not getting rid of the infection. The objective of the lockdown was to slow down the spread so that we don't overwhelm the health systems.
But it's happening now anyway. We're getting overwhelmed at hospitals at reaching capacity anyway.
And that was expected because we didn't wait until the peak arrived and then the decline on the peak to a level of safety. So now basically just picking up from that rate of infection that we left behind, both in China and in Italy, talking about 2 countries that went through it first. They peaked and they waited to reopen until the death rate approached 0 again.
Got it. We opened way too early. Not to mention, of course, the George Floyd riots and such. Were really a lot of people were not social distancing well before we opened. So, okay. So I've had people throwing out these other comparisons and these parallels of different diseases that we want to see. Is this the same pattern? I've heard people talking about H1N1. Well, isn't this like H1N1? Is it like the 1968 pandemic, which had some significant deaths, or is it more like 1918, which killed 50 million people or something?
Well, it's hard to tell because this is a different virus, obviously, and it has a different mechanism of action. It's different times. The population density is different. Comorbidities and risk factors are different. So, we're looking at a different picture. However, instinctively and on the basis of what I know, I think we're looking more at a 1918 type of picture than anything that we are more familiar with.
I've been looking at numbers, and we were looking at New York and going, oh, well, if New York is hit, a certain amount of the population, you're seeing people with antibodies tests and whatnot, then maybe 25% of the population is not even going to be infected. Maybe it could be as many as 50% of the population. And so if you compare the number of deaths in New York to that, then it's only at 0.15% right now in New York. Then maybe that number would only go up by 3 or 4 times for the total death of the state of New York.
Mm-hmm.
And then the death rate would be at 0.5%. Is that good math, or is that not good math?
So this is all estimates, right? So the way I look at the numbers is a little bit different. I look at the numbers in terms of confirmed number of cases and confirmed number of deaths. When I look at that number, it looks like out of 100 cases, 5 confirmed, 5 people die. So
5%.
5% die. And that's consistent across the globe.
If this infected 100% of the population, 5% of that population would die?
100 people get infected and get sick from coronavirus, 5% of these people will die.
So does that 5% get edged down when you have when you say, oh, maybe 25% of the population is not going to be affected at all? Does that reduce that 5% by like 1.5%?
This is what we don't know at the moment. So we know that in terms of the spread of infection, this is where the similarity with the 1918 Spanish flu come out. We know that before the infection stops, you need at least 60% of the world population being infected.
That's for herd immunity. For herd immunity to kick in.
For herd immunity to kick in, but also for the virus not to find sufficient hosts, available hosts, to keep going, right?
So 5% of 60%.
5% or 60% could die. Now, of that 60%, hopefully, we will have a proportion of people that will be infected, but will not develop any symptoms.
Right.
And therefore, that could drop down the number of deaths and active infections further.
So
but at the moment, we don't really know what that number is.
Well, let me just play with this number for a second. If let's say it's the U.S. population, and we're saying that 60% of that population will likely catch the disease, and out of that 60%, right now, according to the numbers around the world, if that 60% is infected, that means we're going to have 10 million people die.
That's possible.
And that's a much higher estimate than most people are throwing out there. Because why? Because there's a lot of other things that we could do to mitigate this if we use our heads.
So there are many things that to mitigate. Is also the use of statistics in terms of extrapolating hard numbers to hypotheses based on an estimate of community spread that we don't have right now. We have very, very patchy data. As I said, the antibody testing that has been used, it's really much like tossing a coin in terms of reliability. We don't really know whether that means anything. We also don't know whether people that have the antibodies are not going to be susceptible to the infections again. And it looks like the permanence of antibodies is only a couple of months right now. So it is entirely possible that people that get infected might become reinfected at a later stage. So I appreciate the desire of minimize and make sure, send an optimistic message out to people. But I feel that that's a little bit out of context in this situation.
So it sounds to me like this really is a lot like the 1918 pandemic. How is this different than the 1918 flu pandemic?
Well, it is very different because this is not just a respiratory virus. It is true that the transmission can occur through the respiratory system, and it's through, now we know that mostly it's through aerosol and droplets, right? So it's almost an airborne situation, which is very similar to the 1918 flu. However, this virus is very specific in the sense that it attacks a specific receptor on the body. It links to a specific receptor on the body that allows the virus to enter cells, which is called the ACE2 receptor. The ACE2 receptor is a widely represented receptor across a number of cells, including lungs, smooth muscle, kidneys, heart, blood vessels. In fact, ACE2 is actually a target for hypertension drugs and for vasodilatory drugs. So it's a pharmacological target already that we use to treat certain conditions that have nothing to do with the lungs, but have to do more with the general circulation of the heart.
The heart.
It's also represented in the guts. So many of the symptoms that we see besides cough and congestion are actually relatable to ACE2 receptor. So gastric symptoms, loss of smell and loss of taste can be related to the ACE2 receptor. Cardiovascular symptoms that we know have been prevalent in patients with the coronavirus can be related to that mechanism of action. Formation of thrombi and coagulation problems can be ascribed to that mechanism as well.
So this could be causing lots of other diseases that aren't even being diagnosed as coronavirus?
Exactly. That is exactly my point, and that brings me to my own experience, where, and to the experience of many others that are emerging, as a growing community of people that experience symptoms for very long period of times, and often those symptoms are not very typical of coronavirus. Might or might not have respiratory symptoms, but most often they are cardiovascular. They could be coagulation problems. They could be circulation problems. Some people express gastric or intestinal problems on an ongoing basis. And we don't diagnose those very well. And we don't consider those as coronavirus infections.
Right, because they're not blaring right in front of your face. They're not as obvious. They don't match the pattern.
They don't match the known pattern of patients hospitalized for coronavirus.
A lot of these people will not even be diagnosed with coronavirus, and they're dying.
There might be people that actually die. So, we have actually seen an increase, statistically significant increase in the overall number of deaths over the last 5 months, right. Mostly for cardiovascular conditions. So heart attacks and strokes. And peculiarly, those happen in younger populations, in younger patients. Those go completely unchecked because these patients are never tested. In those kind of situations, normally don't even make it to the hospital.
Right. So
it's, again, there is a lot that we don't know, and there is a lot that we are not learning from the scientific understanding that we have of the mechanism of action of this virus.
Right. So what else is different from the 1918 flu pandemic?
A lack of seasonality that we observe here. Normally, even if we reopened, if this was a seasonal virus, during this season, we shouldn't be really seeing repeaking to the extent that we are, especially in warm states.
Right.
Even it's that to me is very worrying, because that means that we actually still in the first wave, and we haven't even seen the second wave, which is going to be harder hitting in the autumn, when the air is going to get a lot moisture. So that because the moisture in the air is going to condition how much the aerosol remains suspended, and therefore the overall viral load of air pollution. Yeah.
Right. So then we've also got the incubation period, right? Like 1918 flu, it seemed like most of the time it was killing people within a week or two.
Right. Here it's very different. It's, again, we look at certain cases, we look at a subset of cases of people that have been hospitalized, right? The majority of people that get hospitalized experience symptoms for a couple of weeks before they end up in hospital. And then they are sick for several weeks, and then they start getting better. And normally after a couple of weeks, they they stop displaying positivity to the virus. So we came up with this borrowing essentially from the flu statistics of 2 weeks of up to 2 weeks of incubation, 2 weeks of disease, and 2 weeks of viral shedding post-disease. In reality, I think that there is data suggesting that this is not quite accurate. We know that the virus has been present in China probably since the early fall of 2019. It certainly was present in Europe. I think in Italy, they kind of traced back the first case to October or November of 2019. And in the US, I think it was November or December. The first documented death didn't occur until the first quarter of 2020.
In the US?
So, in the US. So the first documented death actually in the US was this lady in Santa Clara County, I think, in California. And actually the cause of death, to my point earlier, the cause of death of that lady was cardiovascular disease. So there are elements that suggest that while in a significant amount of the population, the pattern might be 2 weeks, 2 weeks, 2 weeks, in a as significant proportion of the population, there might be a much longer incubation period, and there might be a much longer route to recovery after that.
Right, which makes this a much more diabolical disease, if you will, because it doesn't let you know. If you don't have a time period, you can't know how long you need to really quarantine after exposure before you. I mean, like you were basically down for almost 2 months, right?
Yeah, nearly 3. Yeah.
And you've continued to social distance after the fact, just in case you might spread it to others.
Yeah.
Or be reinfected because we're not 100% sure that's not going to happen.
It's a very successful virus. Viruses that are very aggressive and very fast and kill a lot of people very quickly don't get themselves an opportunity to spread very well. Ebola is highly infectious, but it's also highly quickly lethal. So, people get sick very quickly from Ebola, and die very quickly. So the virus doesn't move across society very quickly, very much. This one seems to be much more like the Spanish flu, where it's highly infective, but it's infective in such a way that people carry it for a much longer time, with or without symptoms, and therefore it gives itself a very good chance of replicating and spreading to society.
So the other thing we have to contend with today is even higher density populations in our cities, more crowding, more spreading of the virus, which is potentially even more deadly than 1918. And the only thing we have to fight it with is more science. The fact that we have a lot more medical science behind us to take it on, and if we would only use it. Now, let me just recap what we've got to define this virus as we understand it today, as opposed to 3 or 4 months ago. We know that it's not that affected by seasonality. It's still surviving in warm weather. It has a long and unpredictable incubation period. Could be a week or two, could be 6 weeks or something. Then we have the issue of the ACE2, which means that it's not just a respiratory virus. It's not just going to give you pneumonia. It could also take you out with a heart attack or a stroke, or attack your kidney or your
kidneys, your guts. It could be very multisystemic. It's not necessarily just a respiratory virus.
And it could take a while before those impacts are real to you too. It could take months before you're actually going, oh my God, I'm about to die. So that's sneaky. So the way my mind is imagining this right now is just that the cells have been ripped apart in areas of the lungs. So of course you're having trouble breathing, or if it's gotten into your heart, then it's like actually literally tearing apart your heart.
There is that, and then there is the effect on coagulation. So they could create thrombi, so kind of essentially areas of scarring or areas where the blood coagulates, and therefore it creates what is called an infarction or an area of necrosis, where there is no infection, but the tissue around that still dies. And then you get scars as a result of that, instead of functional tissue. It's gnarly.
It's a gnarly enemy.
Yeah.
All right, now we've got all this medical science that we've developed in the last century. Why are we still struggling to figure this thing out after 6 months, basically, of contending with it?
Well, I can only share my own thoughts on that, and I think that has a lot to do with the way we do medicine. We have this very interesting way of looking at science, where we assume at any given moment, we assume that what we see and what we understand at a specific time is all that there is to understand, and we act on that knowledge as if it was absolute and truth. So, as an example, we saw that a lot of people in China ended up going to hospital, not being able to breathe, and we assumed that this was a respiratory virus, and that people needed ventilation in order to survive. We thought at the beginning that this was transmitted by direct contact rather than by aerosol or suspended air droplets, and therefore we didn't think that using masks would be helpful, and social distancing and washing your hands could have been sufficient to stop the spread of the virus. So we issued guidelines in those terms, and we issued therapeutic protocols according to those observations. And that explains a lot of the inconsistencies or shifting messages that we're seeing coming from Fauci and other experts over the last 5 months. So now we're starting to know more. We move in some of the things, like, now we're asking people to wear masks, because by wearing a mask, you don't protect yourself so much, but you protect others from the possibility that you might be a healthy carrier, and you're not, by wearing a mask, you're not, essentially distributing so many droplets in the environment, right? Or so many viral particles into the environment. But one thing that we haven't done is to take a more broader look at the virus and its mechanism of action and its possible multi-organ function and multi-organ targeting that could lead to numerous causes of death other than pneumonia and respiratory.
Right. So why aren't we strategizing better to think out all the scenarios that the evidence could be showing us that we're just not thinking out?
Well, there are maybe two reasons, right? One is that it's very difficult to correct course when you have a big ship that is heading in a direction, and all of a sudden you say, oops, we actually have to correct and look into many different avenues. That's very difficult to do because, that's an inertia problem associated with that. There is also a problem with the method that we use. So in medicine, we use something that is called evidence-based medicine or evidence-generated medicine, which means that only the data available to us matters as we make a decision. So because we hospitalized only patients with or majority of patients with respiratory symptoms, we focus all of the research and all of the clinical investigations on that subset of patients. But we don't look at patients that never make it to hospital, or that resolve spontaneously, or like me, have moderate symptoms that kind of linger for a long time.
So we've basically filtered out all of the other patterns that might be more informative about how this disease really works.
Right. Yes, exactly. And so clinical research is all directed towards decreasing mortality, which is, the right approach to a certain extent, but it's not the only approach that we should take.
Right. Because what if 5% of the population of the 60% that get it, or less if we're smart, dies, but a much larger percent of the population ends up with long-term health problems because of this virus? Then we'll really be kicking ourselves then and wishing we had been thinking through how to prevent people from having any severe reaction to this whatsoever.
Yes, that's exactly my point. And we almost hang in everything on this idea that we are going to get a vaccine, right? And we might get a vaccine soon. The reality is that we don't know whether a vaccine is going to be available because we have other examples of infectious diseases similarly structured to the coronavirus, where we haven't been very successful in developing vaccines. We don't know whether the immunity from the vaccine is going to be lasting any longer than the immunity that we have from the infections. And at this moment, it looks like that immunity only lasts for a couple of months, and that will not be sufficient to eradicate the virus. We don't know the safety of those vaccines, because normally vaccines are evaluated in very large populations over a very long time. So it normally takes, in the range of about 5 to 10 years to develop the vaccine. And now we're asking ourselves to develop a vaccine in a year.
I looked at H1N1, and they did develop a vaccine within about a year for H1N1.
But that's because we already knew the structure and antigenic map of the flu virus.
Okay.
So we already knew that from a family of this virus. So whereas we don't really have a vaccine even to the common cold, which is the most common coronavirus. So there isn't a lot. We don't have a vaccine to SARS-1, which is the other coronavirus that has been around. So
basically, it's wishful thinking to just hang all of our hopes on a vaccine coming in the next year.
I wouldn't say that it's wishful thinking, but it's certainly very optimistic.
For the young people who really think that they're invulnerable, understanding that they're not, but that wearing a mask, even a cloth mask, reduces the viral load.
So that's a really good point as well, is that by reducing the overall viral load, by reducing the amount of virus that we emit, you get actually people a better chance to develop herd immunity, because herd immunity is more likely achieved when the viral load is present, but it's not sufficient to cause an infection. So that you give the immune, as you said, you give the immune system an option to react without being overwhelmed by the number of copies that are going to invade the system.
And unless you're wearing an N95 or something that's incredibly high, you're still going to get enough. The aerosol stuff is so small, it's going to a lot of it's still going to pass through over time, to the point where you get enough viral load.
But more importantly, what you do by wearing a mask, you release less aerosol in the atmosphere.
Right.
It's the amount that each of us contributes to that goes down.
In the same way, social distancing will help us reduce viral load. It may not eliminate it 100%, but if you're keeping 6 feet distance, most of those droplets are going to hit the ground before they hit you. Right. So it's arguably minimizing your risk of a major infection.
Again, because wearing a mask on its own doesn't really prevent you from taking the virus, because you can take the virus through the eyes. I've seen people wearing the mask under their nose, and you can actually get infected through your nose. If you are elevator that is full of virus, you're going to come out and your clothes are going to be saturated with virus as well as everything else. The moment you move around and kind of flap your shirt or your t-shirt, you release virus into the environment again. And then you have virus on the top of your mask. So if you take your mask and you take it back and you touch it and you don't wash your hands and then you touch your face, again, you put virus on yourself.
The aerosol element, of course, means try not to be indoors
Right.
for long periods of time where you could breathe in enough viral load to infect you.
We don't take those measures to protect ourselves. You know, it's not something that you do for self-defense. It's something that we do for each other because each of us has relatives, friends of friends that might be in some vulnerable categories. So by adopting those measures, we are not necessarily protecting ourselves, because if you're wearing a piece of cloth in front of your mouth and somebody coughs in front of you, you still get enough virus probably to get infected, right? But if you continue to wear a cloth, when you cough in somebody else's face, they might not get enough virus to become infected. So it's not about protecting ourselves or limiting our own liberties. It's really about caring for each other.
Thank you, Fabio. I think this has been really helpful, I think, to get people to understand what the underlying problem is and how to approach this enemy with a little more clarity.
Thank you so much. I thought that was a really good discussion. Thank you for your questions.